So welcome everyone to what is the second webinar in a new NHS providers programme on how trust-wide approaches to improvement led by the board can help in this next phase of pandemic recovery and beyond. For those of you who don't know me, my name's Miriam Deakin. I'm Director of Policy and Strategy at NHS Providers and really looking forward to chairing this afternoon's session. So today we're going to focus particularly on what aspects of improvement during COVID Trust might want to keep in the longer term. How can a trust-wide approach to improvement build on what was learnt during the pandemic to support the service and staff recovery in the challenges ahead? For those of you who joined our first webinar, you'll know that this programme facilitates peer learning. So it's very much about a safe space in which you can learn from each other. And we are really hoping from today's conversation to start distilling some of those actionable insights which we can take away for boards to put into practice. So if we can all kind of hold on to that little phrase, actionable insights, as we listen to the presentations and join in the discussion, that would be really helpful. We're also delighted to be partnering with the Health Foundation in doing this work, which, as you'll know, the Health Foundation's got huge expertise in the quality improvement space, and that's really enabled us to draw on their learning and their community of improvement leads in the work that we're doing. So we've got a fantastic panel for the session, which you're going to hear from today. So I'll give you a little sense of the running order and do a few housekeeping bits before we open up and start hearing from our speakers. So huge welcome to Michael Wilson, CBE, Chief Exec of Surrey and Sussex NHS FT, and to Sue Jenkins, their Director of Kaizen, who we're going to be hearing from first. And we'll hear them present on their recent experiences and then have a little pause for Q&A and a little bit of discussion if there are any questions that you have for them specifically. Our second presentation is then from a trust with a slightly different perspective. So huge welcome and thanks to Kerry Robinson, Exec Director of Performance Improvement and OD at the Robert Jones and Agnes Hunt Orthopaedic Hospital. And she'll be joined in presenting by Alison Jordan, Managing Director of their Support Services Unit, and David Lowe, Improvement and OD Manager. So welcome to you both and really looking forward to hearing about your recent experiences in a moment. Just a bit of the essential Zoom housekeeping kind of before we kick off with the content. So we're in Zoom webinar format as ever again today, but we'd like the session to be as interactive as possible. So if you're comfortable, feel free to put your camera on if you'd like to. If you'd like to come in and contribute verbally, you can use the raise hand function, which is in the reactions button at the bottom of your Zoom screen there. If you can't find it, don't worry, please just sort of wave or even indicate in the chat that you'd like to come in and ask a question. Use the chat box as much as you like, either to kind of comment or to put questions in there, and I'll keep an eye on that along with colleagues on the call as well. We have muted you until you wish to come in to speak, just for the purposes of the webinar, and just to make you aware, we're recording the session so that we can play back the learning to a slightly wider audience afterwards. If you do lose connectivity at any point, don't worry, just re-click on the link and hopefully we will all still be there for you to rejoin. So I think that's everything. If you do come in to speak, perhaps just introduce yourself and your trust as well. We've got a fantastic audience here drawn from a range of board level positions. So non-exec directors, chairs, medical directors, quality improvement directors and other clinical leads. So really good audience for the session today. Just before I invite Michael and Sue to take the reins and run through their presentation, I'm just going to provide a bit of a recap of the core messages which came out of the first webinar that we held. So as some of you might know, this is a series of 3, and while each of them stand alone and each of them is focused on sharing learning in itself, we're also using these conversations to inform our understanding of what support trusts might want from us NHS providers in the future and to kind of refine our offer. So team, I think we've just got 3 slides to pop up just for me to run through the key messages that came out of the first webinar. And this isn't to confine your thinking to these messages in any way. We just thought it might be a kind of helpful backdrop in terms of what came out of our first conversation. So the first message is working through the inevitable tensions between top-down command and control and putting in place an environment which enables people to act and have that kind of autonomy. And I think this really played out inevitably during the pandemic. It's quite an interesting question in terms of what we want to retain moving into the next period of recovery as we move into living with COVID rather than dealing with the height of the pandemic. So that first one there was about this tension between the benefits of top-down command and control and the clarity that that brings with the need to enable others to act. Move on to the next slide. The second message was very much focused on finding the right balance between adherence to improvement methods and understanding the principles of improvement. And I think all trusts, regardless of where they are on their improvement journey, will have a different take on this and might approach this in different ways depending on their context and the challenges that they're facing. And it would be interesting to kind of pull out from the presenters today actually what their approach is versus adherence to quite a strict improvement method versus a broader understanding of the principles of improvement. And you've got a couple of quotes there that sort of illustrate some different perspectives. And the third slide was focused on getting the right balance in governance between quality improvement and quality assurance. So I guess this is using governance really as an enabler of what you want to do rather than getting stuck in the weeds and kind of boards getting stuck in the mud in a sort of unhelpful way. So striking that balance, that was kind of a core question that emerged from the first conversation as well. So hopefully they're helpful just to have in the backs of our minds. And if you're comfortable, Michael and Sue, I'm going to hand over now to you to run us through your recent experiences and your presentation. I think we've got about a 15-minute slot, and then we've got time for some Q&A on the back of that. Okay,
so you're going to put the slides up. So what I do, well, firstly, welcome everybody, and thanks for giving us the opportunity to share our experience. So I'm Michael Wilson, Chief Exec of Surrey and Sussex NHS Healthcare Trust, and Sue is our Director of Kaizen. So we're going to do a bit of a double act. So I'm just going to give a bit of context. So Sue, next slide, please. So for those of you who don't know the Trust, I guess we're kind of a medium-sized district general hospital, about 830 odd beds, just under 5,500 staff, but we serve a big geographical area, which is both urban and rural. It's divided into two, so a very affluent part of the population in East Surrey, and North East West Sussex is a much more deprived part of our population with a very different demographic and social needs. We have an operating budget of just under 400 million, and the Trust has been here since really probably it was developed about 1982, so still a relatively young hospital in comparative English terms. Next slide, please, Sue. So I've been here over a decade, and so have many of my team. So one of the things that largely we benefited from, I guess, is two things: constancy and consistency, and that will be a theme that certainly I refer to as we talk through where we've been in our journey today. So way back in 2010, this will be familiar to many people. This trust was a merged trust. Very interesting that we're up and down the country looking at mergers and group models again. This was a merged trust.
I can't get through on phone audio either.
Okay, so this was a merged trust way back in the early 2000s, actually, so 2002, and was really fraught with problems between 2002 to 2010. Probably holds the record, actually, for having the most chief executives in the shortest space of time. There was something like 7 in 5 years. Was thought to be the worst performing trust in its day, and it was a bit of a political embarrassment, really, because way back then there was lots of money throughout the NHS, particularly in the earlier Blair years. So on all quality metrics, badly performing organisation, all constitutional standards, very badly performing, and at the time had the biggest loan in the country of about 56 million, which kind of pales into significance in today, but way back then it was certainly a national outlier. So we embarked on, we had many clinical reviews in 2010, 2011. This will sound familiar for those people who have been close to those sorts of organisations. So lots of help, a clinical review really about every 6 weeks, and didn't really do very much, because by the time you got one report, you were into the next clinical review. So that will be familiar to some folks up and down the country. We then embarked on our own leadership program. And this was about preparing the organisation over a 2-year period to identify clinical leaders, both in nursing, medicine, allied health professionals, to actually start to think about the shape of the organisation and about the type of clinical leadership that we really wanted, taking the organisation forward. And it was an organisation, so General Electrical, GE Healthcare, it was nothing about the organisation, really. It was more about the people that were running this at the time. Who really could align themselves and were very in touch with the needs of clinical leaders and helped us develop a clinical leadership program over a 2-year period. And what we found really was that actually brought the organisation together, started to focus on the things that mattered. We talked about, and still do today, actually 5 things. Communication underpins everything that we do. How we spend our time and the purpose, which is on patient experience and quality. Safety and striving to get the very best clinical outcomes. In 2014, we were the first hospital actually to be then rated under what was then the Care Quality Commission's new inspection regime, and we were very fortunate to discover that we'd actually come a long way. Our leadership program had really made us focus on those 5 things I've just alluded to. And we'd really started to make significant improvements, but both in patient experience, quality, particularly in clinical outcomes, on a range of things right across the organisation. In 2015, we were one of 70 organisations that applied to the DHSE to become part of the 5 trusts that were partnered with Virginia Mason in the US. And we're still on that programme today. We still work very closely with VMI. In fact, I was with them last week. And I think that has really helped us engage really in a number of things, and we'll talk about this a little bit as we go through. But I guess the principles for VMI for me are around, getting better never stops. It's all about constancy and consistency. It's about creating a climate and a culture. It's about offering people a suite of tools and techniques to actually think through how they would make improvements and changes in their working environment. And then, I guess the most important aspect is getting those people who do the work to improve the work, and really understanding that it's only those people who are going to do that. I mean, as a chief executive, and many of you on this call today will be chairs or chief executives, we think, I guess, and I used to think that we could ask people to do this stuff and they go off and do it, and or we could tell them to do it. And the reality is you can't. You have to inspire them to be able to do that. I think the other thing that this has done for us is create a climate and a culture, and I think for improvement, but also it has been a massive engagement tool. And I think that over the last 5 or 6 years, our national survey results have been in the top 3, the top 4, 5 across the country. And I think that's really come through in terms of, our general approach. So we continued our journey in 2019. We were rated outstanding. It's a moment in time, and I'm the first to say that, for both quality and the use of resources by the Care Quality Commission. And we've, I'd like to think that in 2021, we've actually built on that now and are doing a range of things today that we were doing, I think, we're doing a range of things today differently and better than we were in 2019. So I'll just move on to the next slide. And Sue's going to introduce this.
Thank you. So a lot of our work is based on the Virginia Mason production system, which in turn was based on the Toyota production system. And we've developed our own system, which we call SASH Plus. So when you hear SASH Plus, it correlates to the VMPS or the TPS, which you'll read about in lots of literature around improvement. So we spent some time defining what SASH Plus was to us. And the first thing we said was that it was a management system, not an improvement methodology. We wanted the SASH Plus to be inbuilt into what people do every day and use SASH Plus to help them improve their work. We say that leaders have 2 responsibilities, that is to run the service and to improve their service. And SASH Plus helps them do both of those, both run and improve their services. So daily management is a really important element of our management management system, which enables leaders and staff to do bits of improvement and enable Kaizen, which means continuous improvement, to happen on an everyday basis. So these are the different elements of SASH Plus, and as I was preparing for today, I was looking through and thinking, okay, so which of these are relevant to the board and which are relevant to the rest of staff? And actually, all of this is relevant to the board, and we've been quite key in defining and ensuring that the board and non-executives are as familiar with SASH Plus and what it looks like as our chiefs and our matrons and therapists and clinicians and non-clinicians across the organisation. So the fact that this work links with our values and behaviours is hugely important. We developed our values as part of our work with GE some 9 years ago, and we review them each year, and they haven't changed. They're still the same. We use them as a reference for recruitment, and we use them as a reference for leading. And so when Michael shares his message every week, it's like a blog. He often makes reference to one of our values and how that they are being lived out across the organisation. We have transparent strategy alignment. So we've got a strategy on a page which we'll show you in a bit, so that there's clear transparency around what we say we want to do as a board to what we expect staff to do out on the Gemba and in the areas that they work in. We have a quality improvement methodology, which is based on lean, but it could be any improvement methodology that you have in your organisation. It doesn't have to be lean. Lean's worked for us. We didn't have anything before lean, but having that single improvement methodology that we refer to as part of SASH Plus is really important to have. We have the tools, and the tools are important, but they're not the be all and end all. But what we've developed is a suite of tools, a suite of improvement tools based on lean that we can train staff in at all levels of the organisation. And members of our board, all of our executive team have been through Lean for Leaders, which is a year-long programme. One of our NEDs has been through that programme as well, and we've developed some other education and capability offers for the rest of our board as well. Daily management is hugely important, so making sure that improvement is built into what people do on a day-to-day basis has been a hugely important part of this work, and that comes in the form of daily huddles, production boards, and our SASH Plus boards, which link what we're doing on a daily basis in our clinical and non-clinical areas to the strategic objectives of the organisation. And one of the reflections of this work is that it really helps in levelling the hierarchy. When we're running rapid process improvement workshops, when we're running Lean for Leaders, where you might have a Band 4 team leader from medical records, training alongside a chief or a member of the exec team or a matron, there's a real levelling of hierarchy, which means these are the concepts that we're teaching, go and apply them and then come back and share. And nobody's voice is more important in sharing their reflections and their learning. That was a real tangible and richness that we haven't had in any other work that we've done in the organisation in quite the same way. Coaching is really important. That means leaders have to stop solving problems, which is hard when you're a leader in an organisation and you've got to where you've got to because you're good at solving problems. And so investing in others to solve problems themselves is a huge part of what we try to do and a huge part of SASH Plus. The change in the culture has meant that leaders have a responsibility to go to the Gemba with purpose, ask why, and show respect. We've developed standard work for all of our leaders to use when they do their Gemba walks, and our aim is to empower staff to improve their own work. It's not the leader's responsibility to come up with all the solutions and do all the improvement. And how we respond when things go wrong is hugely important in terms of creating that culture of improvement and empowering our staff.
Thanks, Sue. So board behaviours are really important, and it's the responsibility of the board, in my view, that to create the climate that creates the culture to enable this to happen. If the board isn't behind it, it's not going to happen, and that's certainly been our experience. It's important that the board and the non-execs and the executives work together, they work alongside staff, and they do the training alongside other members of staff. We focus on waste reduction. I can't remember the last time we ran a CIP program. We just don't talk about that. We focus on waste. And actually, you can connect with the clinical community by talking about improvements in patient pathways, by reducing waste, by reducing waiting. It means much more than pitching up to somebody and talking about a cost improvement program. Gemba is the workplace. The non-execs and the board executives visit the workplace. The point that Sue was making about being respectful in the workplace is really, really important. You know, it's really difficult. It's really easy sometimes, you know, when things are not going that well. You know, the executive pitch up in the clinical operations room and start telling everybody how to run the hospital. Well, actually, they've been doing it day in, day out, you know, let them tell you, and they will help you frame problems and then build solutions around them. Sticking to the method is tricky and it's difficult, but you have to do it, and we do that all the time. And as you grow and mature as organizations, as we have, we've learned to develop complex value streams where we're really clear and really rigid about the method, and we use the tools and techniques to do much shorter work, and particularly around, you know, the early days of COVID. Just to give you an example, so when the NHS back in 2020 kind of stopped everything it was doing, we found ourselves, like everybody else did, with empty operating theatres. Some of you, our orthopaedic theatres are all brand new, they're all laminar flow. So what we did is, because we quadrupled our intensive care beds, those people who were shielding worked in laminar flow theatres to prepare all the antibiotics for all intensive care patients right across the organisation, you know, in sterile conditions. So actually, you know, you kind of free people to experiment and liberate them to actually come up with new ideas. Particularly, and we did the same thing, as I know that many of you did, around PPE and a whole range of other things. Being problem framers is really important. It's really easy for most of us to think that we've got the solution, and we don't. We need to frame problems and build the solutions together, and then individual clinical teams will actually own the solutions, and that's really, really important. Be comfortable finding out what you don't know. I mean, you know, I'm still learning every day. I've been in the NHS for 41 years this year, and I'm, you know, pleased to say that I'm still learning all the time, right? You know, and actually that's what you know, kind of makes the job so interesting and inspiring. It's really important to celebrate even small successes. Some of the you know, when you do a rapid improvement workshop and you've got the board involved and you know, patient representative, staff representative, and sometimes the changes are really, really small, but they're owned by the clinical community. Okay, and you get better patient experience, going back to those things that we talked about before: better quality, better safety, better outcomes. And then your strategy's got to be really simple and visible. There's no point having a very complex strategy that nobody understands. That whole thing around board to floor, everybody needs to know what your values are and what you stand for as an organization and how they play into that. And she'll talk about that in a little bit now. Sue?
If I come off mute, that would really help. Sorry about that. So this is how we've tried to simplify our strategy. Our patient is at the top, and we've articulated our vision, which is what we do, and the values is how we do it. And we've taken our strategic objectives that we agreed, probably 7 years ago now. Yeah, it was 7 years ago when the CQC first announced their new domains for how they were going to assess and rate organisations, and we shamelessly plagiarised those domains and made them our strategic objectives. So our strategic objectives are safe, effective, caring, responsive and well led. So our staff are familiar with those objectives, and each year we review our current priorities and say, okay, to be safe, what does that look like? And at the moment we're focusing on reducing avoidable harm, and we have been focusing on reducing avoidable harm for a few years now. And then underpinning that is through integration and partnership. What we want to be is with the provider of choice on a page is across the whole organisation. It's on walls, it's on boards, it's used on production boards, and there's another layer underneath current priorities that says team priorities. So the teams can then say, so to reduce avoidable harm, what is it that I'm going to do in my outpatient team, and what is it I'm going to do on a ward team, or was it I'm going to do in a portering team? So there'll be very different local objectives that in turn help us reduce avoidable harm, and which links to making us a safer organisation. So that's something that our strategy on a page is something that we've developed over the years and is very visible across the organisation.
Okay, so and finally for me, I guess reflecting on what COVID taught us. I think really, if we hadn't really, for us in our organisation, if we hadn't been very much wedded and involved to this, and it's been part of our DNA for a long time, I think COVID would have been a lot harder, actually, for us. We've learned that the management system that we use, it works really well. It's okay to pause it from time to time, particularly when we're in the middle of COVID, and to use the skills, the tools and techniques to do other things much more quickly. We've learned that, and we've learned to be successful in doing that. We've also learned kind of what not to do as well. It's a toolkit for staff to draw on, and I think it's a kind of, because staff are well practiced at this, I think that toolkit became very evident, particularly in the difficult, dark days of COVID, particularly in the early days of March 2020 and so on. The KPO team that we've got are very responsive to the needs of the organisation. They played a major role in helping us think through things, whether that was around PPE, whether that was around fit testing, whether that was around some of the stuff I alluded to before, around the drawing of antibiotics. And it allowed us to think about doing things very, very differently, and helping frame, if you like, those problems and working through the solutions with staff. It's okay to push back when the central timescales are unrealistic. A good example for us was lateral flow testing. The centre, pushed out lateral flow testing, and we said, no, we're not going to do it. What we're going to do is we're going to set up a system, which it's a fantastic system that we have here that our KPO team has set up. So every member staff gets a box of lateral flow tests. There's a proper reporting system in place. It's all done regionally and then centrally. And when the box runs out, another box arrives on somebody's desk. Yeah, which is fantastic. A way of doing stuff, all about to change. We can talk about that later. Visibility of the board and execs is really important. And one of the things I think that we noticed, particularly in intensive care and on the COVID wards where we couldn't go, we missed that and the staff missed that. So we had to find different ways of communicating with staff and doing things quite differently ourselves. And we need to capture and share our experience and learning as much as possible, but don't create an industry. Right? My view would be do what works for your organisation with your people, and that whole thing around consistency and consistency is really important. And then the ability to scale up, improvement and visioning events. We have a lot of those, and we scale down to do short-term task and finish groups. And it's about adapting things to where you really engage the staff. So, we've done lots of things, which, now if you're a senior leader in this organisation, and for many years, even if you're a consultant, you won't be, in our consultant job offers and contracts, they have to do Lean for Leaders. If they don't want to do a Lean for Leaders programme, we won't appoint them. And we are really lucky that we are able to attract consultant staff and senior leaders. So we don't actually have that many vacancies. So I'm going to stop there and hopefully take some questions. I hope that's been helpful, and good luck with your journey.
Fantastic. Well, thank you, Michael and Sue. It's such a rich presentation. I think drawing on the breadth and depth of the journey that you've had there. So I'm going to open up to the floor for questions on the presentation you've just heard there, and welcome to those of you that have joined us during the presentation. Apologies, we had a bit of a technical hitch at the start, so apologies if some of you missed the start there, but please do feel free to use the chat box to pose your questions or wave madly at me, put your camera on and wave, or you can use the raise your hand button as well. So there's some interesting questions from John in the chat there around opting to use some of the CQC language there, and whether that was a deliberate choice. So I wonder if you want to comment on that, Michael, just to kick us off.
So it was deliberate, but I think it's always a bit about translating it so that every member of staff, whether you're a consultant, a senior leader, a clinician, a frontline nurse, or a porter, or whatever, that you understand it means something. The purpose for me is always relating it back to patients and the reason why we come to work. Right, they're really, really important. That actually that there's really clear alignment right from the board, so we're all talking the same language, and for us it was just easier to kind of adopt those things. And for us, we found that it meant something to people.
Absolutely, I think it's good to get that resonance, isn't it? Sue, is there anything you'd want to add on that?
Yeah, I was going to come back on the lateral flow question that John's asked as well. So interestingly, I've only looked at this today because of the conversation we're having around the change in lateral flow kits that's coming our way next week. So our level of reporting is between 68 and 78%. I understand that nationally the level of reporting is 15%, which is why they want to change it. But when we had when we were sent our report a couple of months back, they said we were told we were only reporting between 34 and 50%. And when you take out all the people that cannot report lateral flow because they've been positive in the last 90 days, all those that are absent, they're turnover, so you can't pass the kits on to the next person. So for your leavers and your starters, what was estimated nationally as our 34 to 50% was actually 68 to 78%. So I just think we need to get some clarity. It's really complex, the lateral flow stuff, but we're happy with the 68 to 78% and reckon that, and are continually trying to improve that because it's a safety issue for us, for our staff and our patients.
Absolutely. I suppose it's having that data, isn't it, so that you can push back when you need to. There's an interesting question here from Richard, saying it was great to hear that you didn't talk about cost improvements so much in SIPs. So can you just tell us a bit more about how you balance that then? What's your approach in terms of sort of efficiency and waste, and how do you balance that with the sort of bottom-up improvement?
So we've always been a pretty efficient organisation. So if you look at people argue the issues around reference costs. Our last published reference costs are 83, so actually second best in the country. The latest WOW data, which was published 2 weeks ago, puts us at the 5th best hospital in the country. I always get a bit kind of, I'm never trying to sell anything. Those are the facts. That's what they are, right? We are pretty good on kind of resources. And what we've done is we've been learned to be very efficient because we've engaged the clinical community in a slightly different way. And I think actually, certainly over the last 6 years, where we've used the tools and techniques that we've learned here, actually people really, really like it. There's always more to do. There's always another, hill to climb. But I find that when you talk to clinicians, I'm a clinician myself by background, when you talk to clinicians about CIPs and money, they just look into your eyes and they all mean very well, and then you turn your back and they roll their eyes and walk off. I used to do it myself, okay? When you talk about waste reduction, it means something different. You can have a different set of conversations, right, around, why is it that we don't want these people to wait, these patients to wait? How can we reduce or take out the waste in the pathway and speed everything up so we get better patient experience, we get better quality, we get better safety, and ultimately we're looking for better clinical outcomes. I think it's an easier conversation. I think over the last couple of decades, we've all got a bit kind of, our minds have been a bit contaminated with the fact that, cost improvements are going to sort everything out. They never have.
Absolutely. I love that piece about speaking to people's motivations as well. So there's so much to explore here. I'm mindful of time, so I'm going to hand over to Kerry, Alison and David in a second. Just one more quick question, I think, for Michael and Sue, which is, if there was, in a nutshell, sort of one thing you wished you would have known before starting this journey, what would that be?
So for me, it would have been, we've worked very, very closely with Warwick Business School, and a couple of years ago, Warwick Business School did two things. They did introduced us to a piece of work around culture survey, which was quite detailed, and they did something called social network analysis. And social network analysis is used very much in industry, but not so much in healthcare. And what you get through a range of questions is you get the output is you get a spidergram, and it tells you how your organization is interacting. If I had my time again, I'd have done that. If I'd known about it, I'd have done it in the first couple of months of being the chief executive of the organization, because it would have given you a sense of how your organization is connecting. And that's really, really important. One of the things that we do, and I think it's a really interesting thing, and we'll just labor on this for a minute, I kind of look at hospitals as these large boxes, right? And in them, we've got multi-professional groups. We've got people who train together, people who trained all over the country, people who trained all over the world, right? And what we're tasked to do, right, with all these fantastic individuals is bring them together and create a climate, a culture, and a purpose, right? And that's why I go back to, we have to find things that bind people together. And I go back to those things around really communicating, talking to each other, right? Spending our time on patient experience, on quality, on patient safety, and getting the best clinical outcomes. And I think if you can do that, you get everybody going in the same direction.
Fantastic. Sue, would you add anything from your perspective?
I think my key learning in terms of what I would do again is go with your early adopters. When you think of that change curve and you have your laggards and your early adopters, go with your early adopters. There is so many of them that are keen to get involved. And we made a mistake at the beginning by going with what we thought was the right value of our first value stream, which was cardiology. But the staff weren't ready to do it. And 2.5 years later, we paused that work, having not made as many improvements as we wanted to make on the outset. But there's works going on today in cardiology because the early adopters through the nursing workforce are really grasping the improvements and want to make a difference for their patients in a way that other parts of the workforce didn't. So go with your early adopters. There are enough of them around to make a difference in your organisation, and they'll use peer pressure to get others on board for you.
Thank you. You've both given us so much to think about there. So delegates, please do keep putting your questions and comments in the chat, because we'll make sure that we capture them all and none of it will be lost. I'm going to move on then to welcome Kerry, Alison and David and invite them to give their presentation. For those of you who missed the intros at the start, this is a huge welcome to the exec team from the Robert Jones and Agnes Hunt Orthopaedic Hospital, NHS FT. So if you're ready, Kerry and co, I'll hand over to you. Thank you.
So good afternoon, I'm Kerry Robinson, and as you've heard, I'm joined by Alison, Jordan and David Lowe, and we're going to talk a bit about our improvement journey. We've got quite an act to follow after SASH, so bear with us because it's a bit of a different story for us. So if we just move on to the next slide and give you a bit of context about Robert Jones and Agnes Hunt. We're a leading orthopaedic centre of excellence, single site hospital based in Oswald Street in Shropshire, so we're close to the border of Wales. Small elective hospital, 9 inpatient wards, 12 theatres, circa 1,500 staff. And I've put up there some examples of the improvement work that we've got in, not just in clinical, but in non-clinical. And I share this to show we're a hospital in a field in sunny Shropshire. It's a great place to work as a director, and I'm inspired every day because of what our teams achieve. It was a great place to start with embedding culture of improvement in a hospital. It might be small, but I'd say we bat above our weight in what we've been able to achieve and the improvement that it's helped to deliver all of this. So if I move on to our next slide, it'll probably talk about our improvement journey. So you won't hear us today talk about any of the big improvement names because our investment's been minimal, and therefore it's probably taken us a bit longer, but it's certainly accessible, and we are using improvement method that's best suited to the situation. And I'd say it's taking its hold within Robert Jones more often implicitly rather than explicitly. Our improvement team, well, that's David and I. I'm a board member. I've got a wide portfolio, so it probably informs you of how much hands-on improvement work or teaching method I get time for. David started with us in January as our improvement and OD manager. And we bring in some external support to teach our Improvement Champions programme and support improvement events, probably about 20 days per year. But we started our improvement journey back in 2017. And at the time, I was testing a belief that rather than have an improvement team that the organisation then thought owned improvement, I wanted to test if we could get improvement into the grain of the organisation so that everyone owns it. And we're going to tell you how we got on today. and how that's helped us through COVID. But where are we today? It's in my title. I'm Director of Performance, Improvement and Organisational Development. It's a long title, but it's a signal. We're doing things differently. We've not followed the traditional view of roles and portfolios on an NHS board. We thought about, how do you get performance if you don't focus on improvement? Performance doesn't change overnight, even if we wish it to. And what do you need for improvement? Well, an environment that feels safe for testing and trying, staff that feel safe and infused to make changes, hence the focus on organisational development, all hopefully adding to a learning culture. So if I move on to our next slide, our journey began back in 2016. Robert Jones at the time requires improvement with CQC. We were a fairly new exec team in place, and we were in breach of licence with what was then Monitor. One of those breaches for in our licence was for culture. And as you've seen, we've overcome both of them. But I can't say it's been achieved with just one thing. It hasn't. It's been a focus on performance, improvement and organisational development. And you can't stop. You have to keep consistently developing these areas, living and breathing it, leading by example, keeping the energy and at times holding your nerve. But most of all for us, it's been about making it accessible to all. Part of our success is our staff are using the method without realising they're using it. There is no fancy language. It's just how we do things. So you won't hear us use language like Gemba in our organisation. You might hear go see. We know what the language is, we just don't use it. And we haven't got a published improvement method, but we are using method. In fact, we used improvement method in setting up how we were going to start this journey, and it's gone from there. We used the square root of N, something that Dr. Brent James described in his conversation with Deming. I'm going to simplify it. How many people do you need to capture for it to take a life of its own? For us, with around 1,500 staff, we needed around 40 people. That was the focus. And as ever, we would be doing improvement without a driver diagram, which we've got on the slide there. So we launched our improvement champions in 2017. We're now on cohort 5 days of improvement method taught, but with a requirement to deliver an improvement project and an application to get on the course. It's all underpinned by management support, coaching, internal experts, reference material and self-directed study. And all the projects that get delivered are linked back to our organisational trust objectives. And at the end, there's a celebration, a marketplace, which is attended by all of our board members. We've had some amazing projects from that course. We've had computer learning to predict what patients would DNA. We've improved duty of candour, standardising contrast use in CT and MR, a focus on our new starter process, our outpatient clinic outcomes, patient-reported outcome measure processes, standardising implants, and recognising patient deterioration. And that's just a few of them. It's not all of them. What we did through those champions is we've created a cohort of staff across the organisation who have found an area of interest in improvement method, and then they support others in the improvement challenge. If they need a specific method, they can be contacted through our intranet. We've got experts in process mapping, 6S, swim lanes, PDSA, measurement for improvement. I could go on. And we've also got numerous members of our staff that are members of Q, because we've utilised all the improvement work and support that's out and about and around us to succeed. But where does the board come into that? If I add on to the next slide, the bit of a journey that we've done in assurance. So at the same time, we've been doing all this work in improvement in the organisation. We started embedding measurement for improvement, utilising the NHSI work on making data count, SPC being built into our board integrated performance reporting. Slowly but surely, you can see over the years, we've gradually changed it, thinking about assurance and improvement, measurement for assurance, measurement for improvement. Each committee of our board now has its own integrated performance report. We've cascaded it right through the organisation, our units. This is goal deployment in action. We did it really slowly. And this year, I'm proud to say, we've managed to take the RAG ratings away, which I'm really proud of. So this is performance and improvement intertwined. And at this point, I'm going to hand over to David and Alison to give you some of the examples of what goes on. David, you're on mute.
The classic Zoom mistake, apologies down there. As Kerry has alluded to, during my very, very short time at Robert Jones of 6 months, we have expanded our improvement repertoire through adapting to working in Microsoft Teams and embedding the lens of improvement science and thinking in our preparation to restart our services. So from a small selections of improvement programs pre-COVID, as you can see, which is all happens almost face-to-face, we have now widened to take account of the opportunity that has allowed us to align with operational necessities, such as our outpatient transformation program, our delayed transfer of care projects, and our cancer program, transition from face-to-face facilitated events to learning new ways to reproduce and maximize our outputs while working virtually and also together in our new reality during COVID. And in doing so, we have made absolutely fantastic strides in our journey, such as making sure our widely celebrated Breaking the Cycle events, which I shall come onto in just a few moments, is now part of our improvement arsenal and tools and part of business as usual. And our commitment to further spread the improvement method and our philosophy through, as Kerry has alluded to, through our continued recruitment to our Improvement Champions program. Furthermore, we have that feedback mechanism through our after action review. So we continue to learn what has happened, celebrate what is great, so that we can continue to improve throughout our organization. Saying all this, the journey has certainly not been plain sailing, but through resilience, perseverance, appreciation, and continued curiosity, we believe we have come such a long way from where we were previously. And breaking the cycle, and which is what I mentioned just a few seconds ago, is the most improvements practitioners, as Kerry has said, we refer to as our rapid improvement programs or the Kaizen events. We use this language purposely, breaking the cycle, to purposefully and vividly describe our continuous improvement philosophy. And that is to make step changes, we need to pay attention to our habits and patterns we currently do within our processes and our system that accumulated into the problems we are trying to solve. We co-explore problems through understanding each other's systems and also appreciating each other's needs using narrative such as storyboards, coupled with a more traditional technical methods of process and value stream mappings. We also co-design our commitments and our shared purposes for the outcomes we want to see for our organizations through challenging, honest, and open conversations. And we co-improve through a series of brainstorm solutions and testing through PDSA cycles with support and fantastic support from our managing directors such as Alison and our execs such as Kerry, communicating and celebrating our journey to the rest of our organization each step of the way. And this method is a slight divergence from the traditional rapid improvement event you might come across. But why is this? We have done this purposely, but why do we do this? In a complex system such as our healthcare environments, having a rigid method to control the outcome can just be as detriment as having no improvement method at all. So we always face the paradox between needing stability and control through a rigid structured method to achieve outcomes, whilst battling with the intricacy of humanistic needs such as personal security, belonging, and connection. And as such, we must pay attention to the relationship aspect of our environments, and in conjunction with scientific methods, utilizing feedback from the performance side for improvements in our culture to truly foster and shine. Our paradigm here in Robert Jones and Agnes Hunt is to have these three parts: in perfect balance and harmony and coexist as one holistic entity. From that, we can truly start to shift our culture from sticking a plaster to continuously improving through curiosity and continuous learning. Only then can our organization flourish through new and wonderful innovative practices to better our staff, patients, and our community. And what does this look like? So as you can see from the right-hand side and in salmon pink, our OD program of work acts as a glue to all the improvement work that we do, building upon our interdependent relationship with each other, our departments, our system to achieve a cultural symbiotic learning ecosystem. Our main body of work focuses on the human relationship aspect, such as enhancing our staff to be able to have those safe coaching conversations, pay more attention to the civility and respect and how that affects performance and the safety of our patient and staff, and providing and having those safe spaces for our staff, especially from those from minority groups, to openly have and honestly express their experiences, allowing us to seek ways to co-create solutions to better their experiences at Robert Jones. A strategic wraparound to the program of work comes in the form of establishing faculties such as the human factor faculty, now, as well as our coaching faculties for these to flourish with frameworks to guide our staff to a better improved capability and capacity to improve, resulting in an even higher quality of outcomes for both our patient cohorts and our staff. So from this, I'll now hand over to my brilliant and lovely colleague, Alison, which will take you through some of the operational improvement outcomes using our paradigm. Alison, over to you.
Thank you, David. So my name's Alison Jordan and I joined the Trust in September 18. And with support from Kerry, a board member, I implemented pre-COVID breaking the cycle. And that focused on areas classed as too hard to fix. And we broke barriers right across clinical and non-clinical. And this is with regards to our admission booking process, which people, it had been like that way for years. You're never going to be able to break the cycle. And we did. We had tears along the way, a really good action plan, and we've flourished ever since then within our admissions process. We also set up 642, which is the golden standard for scheduling theatres. It started off on paper, and that's morphed now into a real smooth electronic weekly meeting where we can schedule patients ahead within theatres to ensure we've got the right staff, right patients, the right place at the right time. We've utilised improvement champions right across the trust. So different people, different bandings with really good skill sets that we've utilised to ensure we've got improvement in key areas. So we'll talk about our outpatient clinic room process, very, very difficult, but actually with our breaking the cycle and our improvement champions, we broke down barriers. I move you into phase one, which is ring fencing certain services when COVID hit. So we used our improvement champions. We had a plan for holding outpatients and identifying urgent versus routine, and we improved patient communication by using technology and experts to maximise what we had available to manage patients on the waiting list. So phase two, very, very different for Robert Jones. We set up trauma. So, think about our colleagues who've just done that wonderful presentation prior to us, a very big trust. We're a small trust, we're elective only. So to set up trauma, very new, very different. We had to set up fracture clinics very quickly. And we used our breaking the cycle plans, and we worked collaboratively with other trusts to deliver this good service whilst maintaining COVID IPC processes, all very new, all very different. A bit like coming to work wearing your jumper on back to front, but eventually it became comfortable. But people were confident because we instilled that confidence. We supported each other. And that improvement methodology soon kicked in to support the teams and give them that confidence. After action review, really a safe space, really helps us understand where we've done well, where we can improve. So we're constantly looking to improve. So phase three, we repatriated trauma. and we use the PDSA of trauma to really understand some key learns for the trust and build that back in. We set up some robust urgent bookings and we had an awful lot of challenge on what was classed as urgent and not urgent for an elective orthopaedic. And we wanted to provide assurance to our patients, our trust and our board around waiting list management. We very quickly got clinical prioritization in place, and we had a team that was ring-fenced to focus on consultant and patient. And these weren't high band people. These were people at, band 3, band 4. And they really identified those patients, worked across the trust and worked with our colleagues within Shropshire to ensure that we could identify which patients required surgery in a short time frame. New process was set up very quickly, new flow charts, and we used all our improvement methodology to build and ensure that we covered all aspects of patient access and flow. And whilst doing that nationally, as well as probably most of my colleagues on this call, we had to do the electronic review, the e-review of all patients on your inpatient waiting list. Again, working with various different data sets. So we utilised our improvement champions to support with ensuring that all our processes and all our plans were robust. And we had a bit of all hands to the pump, but it was in a controlled manner. And we'd learned from our previous PDSA cycles. And we were doing this whilst ensuring that we had our patients booked in for surgery. So running two new methods there. So phase 4 came, another period of shutdown. So what had we learned this time? So we went back to our PDSA, we looked at our after action reviews, and the best thing, and I think this is really important message you want to get across, rather than bringing trauma back into Robert Jones, we decided to send our staff to the various hospitals within the region to support, because that was the best thing to do. We reviewed all our patients again on hold, we checked our processes, we further improved our patient communications, and we wrote to 3,000 patients on our inpatient waiting list, and we documented all the replies onto our EPR system. That might not sound a lot to some of the bigger organisations, but a small trust, that was a huge task in a short space, and it was great. We had all the secretaries working together. We had people from all over the admin functions working together to ensure that all those patients' replies were documented. And during this, we still had the e-review process ongoing, because we had various phases where you've got to submit. So phase 5, restart. We're all back at that place now where we need to restart and start, getting through these backlogs. So we used all our improvement methodology that we've learned at our last rounds. We had waiting list initiatives that we've set up. And interesting that we talk about SIPs, because I've got a SIP call after this to talk through the efficiencies within my unit. And I'm going to use that terminology of waste management and patient waste. I think that's a really good way of looking at it, because part of our waiting list initiatives that we've put forward for our SIPs is to improve our DNA rate, which is at 5%, but we want to get it down to 3.5%. We have had a system PTL, and we've held the ring on managing patients across 3 trusts. With this came setting up a very new radiology booking process. And I can't tell you how difficult that was. The obstacles to overcome, the hearts and minds that we've had to win to improve whilst balancing our IPC guidelines, which we viewed as an enabler, not a blocker. We've got governance meeting structures in place within all areas to ensure that patients managed across the waiting lists are all there in place. We've got technical planning as well that we've had to set up with our NHS guidelines. So we've used our improvement learned then to inform that cycle better. And also around our ERF funding, which I'm sure colleagues are working on as well. So moving on to the next slide, please, David. So this is a graph that looks quite a busy graph, but that really just shows you where we've been and where we are now. And that observes the NHS cases that we delivered. We're a slightly different trust. We have what we call our in-job plan capacity, and we use a business function of OJP, out-of-job plan, where we pay resource to come in and do various operations for us at key times. At certain points, it was unknown if trauma was definitely going back. So that was at the 19th of August. We had a clinical risk summit to transfer and repatriate back for the 24th of August. We had to spend some time retraining our surgeons because they'd had quite a gap if they hadn't been doing urgent surgery. We had to retrain anaesthetists and our theatre staff because they'd been just under 6 months not in theatre. So we held numerous sessions with double surgeons present for safety reasons. We had more IPC and PPE rules in place, and that helped us support with our September theatre schedule. And we had theatre sessions, and we also held a what we called an emergency theatre, so we could deal with any emergency that come in. So a very, very big period of change for Robert Jones there. So that's part of our story. So next slide, please, David. So outpatients, I want to just focus on the theatres. So we maximised our core capacity. We've got the timeline for our waiting list initiatives, and we implemented telephone and virtual appointments. Again, very, very different. We invested in technology. And what we soon realised was that, you know, we needed to have a virtual receptionist in our waiting room. There's nothing worse if you're sat in a Teams or a Zoom call and it's blank and you don't know whether you're going to be seen or not. In a face-to-face waiting room, you can see the busyness of clinicians and non-clinicians around you. So we've got a virtual receptionist to help patients there and help with our patient flow. We invested in our workforce. We reviewed our estate to ensure we released capacity and that every room was being utilised for clinical elements of work, at least 85% plus. We have an outpatient improvement board, and we cover booking and scheduling, capacity and staffing. We're looking at doing things differently. We bring in our diagnostics. We've got a whole load of digital enablers to make sure we fully use Attend Anywhere. We've just initiated the patient-initiated follow-up in clinic protocols to help support waiting list initiatives. So I hope that gives you a flavour of what we've done to actually get improvement throughout the trust. And I think for me, breaking the cycle is just a fabulous term for how because it sets everybody up that we're going to make the change. So I'd like to leave you with that point if I can. And I'm now going to hand you over to Kerry.
So I think Alison's just given you a load of practical examples of how we've used improvement in real time and made it work. I wanted to finish with this slide, and Michael talked about this a little bit earlier, which is kind of nice that the two come together, because I was lucky enough to hear Dr. Nicola Burgess at the Health Foundation event give her interim findings on the NHS BMI partnership, and this was one of the slides that she presented. So I wanted to finish on it because it struck me at the time it was what we were experiencing and testing. And it just feels right to conclude with that. It's not just about the improvement method, the technical process, it's also the social system, how we relate to one another. For us, we call that OD. So as a board member, my role in this is making sure the social and the technical interlink. I take the time to be interested. Our Improvement Champions programme, the afternoon sessions are action learning sets. I make sure that I'd attend at least 2 of those and run them with them, because that's my chance to go see. It's my chance to put the energy so that our improvement champions know how important our board feel about improvement. But what else do I do? Holding my nerve. That's often the statement. I have a statement in my head when I'm feeling under pressure about the pace of improvement, and that's trust the method. Trust the method. And that often comes when I'm managing the tensions with our regulators. They want something right now, and improvement doesn't happen right now. It takes time if you're going to do it right. It's not a sticking plaster. But by trusting the method, it helps because measurement for improvement is inbuilt. So I know my numbers. I have a view on the future and I'm able to talk them through that view. It's about managing their expectations on pace so that we are able to do that true improvement and not the sticking plaster. And that's much easier for me to do with it being built into our assurance and governance through the integrated performance report that we've got at our board. And then there's the internal tension in our trust performance meeting. We don't have a trust performance meeting. It's a trust operational performance and improvement meeting. There's an inbuilt requirement that our units provide both delivery assurance together with their improvement work. And David is there connecting that across the trust. So what's our trust-wide improvement work? All of our exec team are in attendance in that. So my job is about ensuring we're building improvement into the grain of everything we do. But mostly, I just bring the energy and I stay consistent. That's the message I can give you. So I hope you've enjoyed our presentation. It's been great for you to invite us to do this, so thank you.
Thank you so much, Kerry, David and Alison. What an amazing compliment to the journey that we heard about from Michael and Sue earlier. And I think Sue's posted in the chat really helpfully. So very different trusts at a very different point of your improvement journeys, and you've deliberately taken a very different approach, but also lots of kind of core principles in common and kind of core techniques that you've used there, which I'm not going to repeat because Sue's really kindly done it for me in the chat. So do take a look at that, and something we can perhaps do a bit more work to pull out in NHS providers. So we've a few golden minutes left, which I'm going to make the most of. So colleagues, please do post any specific questions that you've got for our speakers there in the chat box. Meantime, I'm just going to pick up one that's come out from a couple of people, which I thought was interesting. So Lucy and I think Lynn have alluded to this as well. Just thinking about in the improvement cycle, we obviously want to stop doing things that don't work so well, but that can mean that boards have to tolerate a little bit of failure. And I just thought that was interesting in the NHS. We don't like failure, do we? So I just wondered if you could say a few words about how you approach that with the board. Tricky one.
Yes,
maybe Kerry first, if that's okay.
Yeah, I guess it's that the tolerance piece. So over time is having assurance lined up with it that says we can see this is failing, so it makes them more confident to say we need to stop and do something different, and building that improvement method into what we do at board that goes, okay, and that's the bit I'm describing about holding your nerve. It's not always going to work. You might have to change direction, and that's okay as long as you've got visibility and measurements in there that you can see it, that that's what's happening.
We work on the basis that failure is hugely important as part of your improvement journey, and you can't improve without failure. You have to enable failure to happen and for it to be safe for it to happen. So stop the line is a process that we've put in place. We want to get to a position where anybody can stop the line if something isn't safe. And we've used stop the line when we had a prosthetic. The wrong size prosthetic was put in a hip replacement, and it was the patient that noticed after the surgery, and we stopped all hip replacement surgery for 72 hours, which, you know, when you're an acute DGH, and that's one of your money spinners in terms of income, it was absolutely the right thing to do. So we could really learn in terms of what's the mistake proofing we need to be be able to put in place. How can we talk to staff around what happened, and also how do we respond to staff that identified this as an issue? So failure is hugely important as long as it comes with learning, and it's that learning opportunity which organisations that are on a journey of continuous improvement need to have more of.
Absolutely, and there's a few comments in the chat saying that the CQC is now looking a bit more seriously at how that continuous improvement is evidence, which is actually really welcome, isn't it? That's quite a big step forward. So I'm going to squeeze in another question from the chat. So this is an interesting one, which we've not touched on, interestingly. So thinking about patient voice, co-production, co-design. Sue, I don't know if you've got any reflections on how that integrates with your approach, and then I'll perhaps come to one of Kerry's team as well.
So we've run 41 rapid process improvement workshops over the last 5, 6, nearly 6 years, and we haven't run any since last February. Last week was our first one, and we on 95% of those RPIWs we've had patients in the room as part of the RPIW Rapid Process Improvement Workshop team, who are coming up with ideas and testing them on the Gemba where the work's done, and saying, yeah, this is going to work or this is not going to work. Hugely important. And also one of our metrics in terms of high level is around patient experience. and engagement as well. So patient voice, hugely important in terms of all the work that we're doing.
Thank you, really helpful. And Alison, were you going to come in there?
Yeah, we have a patient panel meeting. So we go, and I often talk to the patient panel meeting, and I'll take, if we're making some changes to letters around fasting, anything around the admission booking process, anything that's, that's touching the hearts and minds of the patients, we'll go to patient panel and have that discussion. And, so they're part of the change.
Really helpful, and some extra notes people have put in the chat there as well. So I'm mindful of time. There are a couple of unanswered questions in the chat box, but I suggest colleagues at NHSP will kind of keep a note of that, and perhaps we can wrap them into a bit of follow-up, because I did want to take just a couple of minutes to reiterate our thanks to the panel. Really rich and thought-provoking presentations from all of you. So huge thanks to Michael and Sue, Kerry, Alison and David. We really appreciate your time, and those of all of you attending, because I know it's super busy, continues to be super busy. So I guess the kind of key messages coming out for me really are around those kind of commonalities between the two very different approaches. So something there certainly about that board visibility and leadership, which we're very focused on in NHS providers, as you know, but also about celebrating success. You both sets of speakers talked a lot about using the data in a very informed way. And you'd both been really thoughtful about your selection of a method, and you'd drawn on external expertise where it served you. So I thought that was really interesting. But most of all, it's probably that point that Kerry ended on around kind of curiosity, holding your nerve, and not letting go, which kind of struck a real chord. So thank you again. Just in terms of next steps from us, we will be doing the final in this series of webinars on the 9th of July. So that's a focus on quality improvement in a system context, which is quite pertinent to the now. So if you'd like to join that, please do. We're also going to be developing some action learning sets, which we're really excited about. And we'll be sending you some information about that and about some virtual visits and other resources soon. So remember, this is all a subsidised offer for NHS providers members. So if you are interested to send someone along or register, please do and make the most of the offer. And as ever, please do fill in your evaluation form to let us know how helpful this was, where you'd like us to focus a little bit more in the future, and what we can take forward for you in more depth, because we take all of your feedback really seriously. So we're just on a minute to time. So I'm sorry we ran out of time. Really, we could have kept talking about this for much longer, because there was so much depth in both of the presentations. But thank you all for attending, and thanks again to our speakers.